Hi everyone, I'm Dr. Divya Shanthi and welcome to NEET PG Core Revision series. These series are structured, focused and exam oriented so that you can recall faster and more confidently in your exams. In today's session, we are going to break down the anatomy of basal ganglia, otherwise called as the basal nuclei, into clear-yielding exam-focused concepts. So let's get started. So the basal ganglia, they are large masses of grey matter. They are large masses of grey matter which is present within the cerebral hemispheres, each core of the cerebral hemispheres. And they form, basal ganglia, form the important component of extrapyramidal system. So these basal ganglia are now called as basal nuclei, but still both the terms are used. So anatomically, when we see the basal ganglia, it includes three portions which we see here now. We have the corpus striatum. So we have the corpus striatum, and then we have the caudate, the claustrum. So we'll have the claustrum in this part, the corpus striatum, and then we have the amygdaloid body. So these three, so the corpus striatum, the claustrum and the amygdaloid body, they form the components of the basal ganglia. So when we come to the corpus striatum, so this is situated lateral to the thalamus. So it is lateral to thalamus. So this is completely divided into two portions. So this we call it as the lentiform nucleus, and this we call it as the caudate nucleus. So the internal capsule, so the internal capsule, so if we see here we have the internal capsule in this portion. So here will be the internal capsule, and that will be dividing it into two portions, that is the lentiform nucleus and the caudate nucleus. So this is the thalamus here. So it is situated lateral to the thalamus. And here we have the amygdaloid body. So the lentiform nucleus, so the corpus striatum now consists of caudate nucleus and the lentiform nucleus. And the lentiform nucleus will have two parts, a darker lateral part which we call it as the putamen, and a medial paler part called the Globus Pallidus. So phylogenetically when we see, the corpus striatum has got two functional units. So corpus striatum, we have two parts, that is when we see according to its evolution, corpus striatum, that is paleostriatum, and neostriatum. So corpus striatum will have this two portions, that is the paleostriatum and neostriatum. So paleostriatum, when we say here, it includes, paleostriatum will include the Globus Pallidus as well as it includes Globus pallidus, whereas the new striatum will include the Putamen and the caudate nucleus. Okay, so the Globus pallidus is basically relatively ancient compared to the Putamen and caudate nucleus. So Globus pallidus and Putamen belong to the lentiform nucleus of the corpus striatum. Right, so we will see a little bit more about caudate nucleus. So caudate nucleus, when we see here, it looks comma shaped. Okay, comma shaped grey matter. Okay, surrounding the thalamus. It will be around the thalamus. Okay, and itself it will be surrounded by the like above we have the lateral ventricle. So it will have a head. The caudate nucleus will have the head. Okay, so here we have the head, body, and the tail part. Okay, and the tail part will terminate in what we call it as the amygdaloid body. Then we have so we can see here, this is the lateral ventricle. So the head is in relation to the anterior horn of it. The body will be in relation to the cavity here, we can see. And then we have this is the tail. Okay, this is the amygdaloid body. And these are all the anterior perforated substance. So the tail will be in relation to the posterior horn as well as to the inferior horn of lateral ventricle. Okay, so this is about the little bit about the caudate nucleus. Then we have the lentiform nucleus. So lentiform is large. Okay, so it is like a lens. Okay, it is large, lens shaped, like biconvex, lens shaped. Okay, lens shaped. So it's also the grey matter. Nuclei in the central nervous system is nothing but the grey matter, right? Collection of nerve cell bodies. So that is why there is the term ganglia too there. But usually when we say ganglia, it refers to the collection of nerve cell bodies outside the central nervous system. So this is large lens shaped and grey matter, which is seen beneath the insula. Okay, the insula is the hidden lobe, right, of the cerebrum. So it will be below that. So here a vertical plane. Okay, so here a vertical plane of the white matter, that is we call it as the external medullary lamina. It will divide the lentiform nucleus into a larger part. This is the putamen. Okay, and this is the globus pallidus. Okay, these both together, this is the globus pallidus. So the putamen is darker. Okay, it's darker compared to the globus pallidus. Globus pallidus is the medial part, which is pale. And this is again divided into two portions by an internal. So this is the external medullary lamina. External medullary lamina. And this is the internal medullary lamina, which will divide it. Okay, so the globus pallidus will be divided into two parts here. Okay, into outer and inner segments. So why is this basal ganglia important? Okay, so it forms an important part of the extrapyramidal system. So because of which it is concerned with planning and programming. Planning and programming of voluntary movements. Okay, programming of voluntary movements. Then it determines how rapidly a movement has to be performed. Now if I want to move just like this, okay, so this movement, okay, it is determined by the basal ganglia, how rapidly a movement has to be performed, okay, rapidity of the movement, and how many muscles, how large the movements must be. Then third, it will decrease the muscle tone. Okay, it will decrease the muscle tone and thus inhibit any unwanted movements. Inhibit unwanted movements. Okay, muscular activity. Then it will also regulate the muscle tone. Okay, it will decrease the muscle tone as well as regulate the muscle tone. So when it regulates the muscle tone, there is smooth voluntary movement. So when I am moving my hand like this, there is this smoothness. When I am lifting something, there is that smoothness, right? So that is regulated by this basal ganglia. Then it also controls the automatic movements associated with automatic associated movements. So for example, when we are walking, we swing our arms, right? So that automatic movement is controlled by it. Then it controls the group of movements for emotional expression. Okay, so anger or sadness, okay, as well as controls the reflex muscular activity. So because it is all to do with our movements, so any abnormality, disease of these basal ganglia will affect these things. Okay, so we will see about the disorders. So the lesions, because it controls and the muscle tone, it decreases unwanted movements, it brings about smoothness of the movements. Okay, it coordinates the movements, like any associated movements, it helps in the coordination of that. So because of all of these things, any lesions of the basal ganglia will result in unwanted involuntary movements. So there will be two things mainly. One is there will be unwanted involuntary movements, and second thing, there will be disturbance in the muscle tone. Okay, so this can be seen in various type muscle tone. So Parkinsonism, chorea, athetosis, Hemiballismus. So these are some of the disorders of basal ganglia. So first we will see the Parkinson's, which is very common. It is also called as paralysis agitans. So this usually occurs with more than 50 years of age, with people more than 50 years of age, and this is mainly due to the deficiency of dopamine. It is the neurotransmitter. So there is deficiency of dopamine in the corpus striatum, and that leads to basically the deficiency in corpus striatum is mainly due to disease of the substantia, any lesion in the substantia nigra, where this precursor of the dopamine is produced. Okay, and that through the nigrostriatal fibers comes to the corpus striatum. So dopamine is synthesized there in the melanin containing pigments of melanin containing pigmented cells of substantia nigra. Right. So what does this dopamine do? The dopamine will be causing inhibition of cells. So this causes inhibition of cells within the corpus striatum, so that any unwanted movements are in corpus striatum. So basically the neurological changes in Parkinsonism will be mainly due to the release of the release phenomenon, because it is inhibiting these cells, right? So since there is no inhibition because of the lack of dopamine, there is some kind of release phenomenon there, and that is because of the deficiency of dopamine. Right. So what are the characteristic features which we see in case of Parkinsonism? So what do we see? We see, okay, so here we can see this is the corpus striatum, the nigrostriatal fibers which will be carrying there. So the first thing which we see will be the resting tremors. So this will be like, the slight shaking movement of the hands, especially when the patient, as the name says, is resting, is not doing anything. Okay, with any movement, these tremors will decrease, they disappear. And they are exaggerated. Okay, whenever there is any emotional excitement, it gets exaggerated. Right, because it controls the group of muscles which is responsible for emotional expression. Right, so because of which here, there is resting tremors when the patient is doing nothing, okay, and when he starts movement, it decreases, and when he is emotionally excited, it becomes exaggerated. Next, the rigidity we call here, the type of rigidity, we call it as lead pipe or cogwheel type of muscular rigidity. Okay, so this is mainly because of the increased muscle tone, cogwheel type of rigidity. So here you have to distinguish it from the upper motor neuron type of rigidity, which is basically clasp knife. We call it as clasp knife rigidity. So it is the rigidity initially, then it just goes, but here it is cogwheel, there is rigidity throughout. So that is called as the lead pipe or cogwheel. Then we have the third, pill rolling. Okay, pill rolling movements of hands, pill rolling movement of hand. So what is the pill rolling movement of hand? So here the patient will be doing something like this, rolling of this thumb and the index finger, okay, in kind of, especially when they are in the resting tremors, during the resting tremors. Then fourth thing which we see is the mask-like face. Okay, so there is loss of facial expression. And this is basically due to lack of control of the group of muscle movements, which is responsible for the emotional expressions. Okay, so because it controls that movements, right? Now there is loss of control of those movements. Because of that, there is no expression. There is just mask-like face. And then we see stiff shuffling gait. Okay, stiff shuffling gait, and this is basically because of the rigidity of joints. Then the posture is stooped posture, and there will be generalized slowing down of movement. So when we see here, this is something like this. The patient will be stooped for posture and general slowing down of movements. Then there is the shuffling gait, okay, stiff shuffling gait. So usually the treatment here we do is by giving L-DOPA, which is a precursor for dopamine. That is the mainly thing, and there are other modes also like striatal implants, okay, so which basically consists of striatal implants of dopamine containing the dopamine containing neurons of fetal origin. So these are implanted there, and also by the administration of L-DOPA, which is a precursor for dopamine. So that is about the Parkinson's. Then we have the athetosis. So athetosis mainly consists of slow, sinuous, rhythmic movements. Okay, rhythmic movements. So this is typically these things we call it as the athetoid movements. Athetoid movements. Okay, slow, sinuous, rhythmic movements, we call it as athetoid movements. So this is usually, it involves the distal segment of the limbs, basically the movements which occurs of fingers and toes. So this is basically due to lesion in the fingers and toes, and this is due to lesion in neostriatum. So neostriatum includes what? Neostriatum includes lesions in the neostriatum, which includes the putamen, okay, and the caudate nucleus. So neostriatum and globus pallidus also. So globus pallidus belongs to the paleostriatum. So it includes both lesions here. So because of the lesions, the neuronal circuit is broken here, okay, involving between the basal ganglia and the cerebral cortex, and that results in this 𝗖𝗙𝗙𝗚𝗏 movements. So you can see, so only the distal portion of the limbs are involved. Then we have the chorea. So chorea is of two types, the Sydenham's chorea and the Huntington's chorea, okay. So here this is basically characterized by quick, jerky, okay, jerky and irregular, purposeless movements. Okay, and this movements here, it involves the tongue, okay, the tongue, the face, the limbs. So there will be shift grimaces, they will be making kinds of all faces, as well as they will be moving their head, okay, quick movements of the, sudden movements of the head and limbs, okay. So they will be doing that involuntarily, it will be happening. So that we call it as chorea. So this chorea can be Sydenham's chorea or Huntington's chorea, okay. So you can see in the picture, the continuous movements will be happening involuntarily. So what is the difference mainly between the Sydenham's chorea and Huntington's chorea is, so Sydenham's chorea here, Sydenham's chorea, or it is also known as the 𝗪𝗏𝗏𝗏 dance. So here it is basically, it occurs in children. Okay, it occurs in children between the age of 5 to 15 years. And mainly it affects the girls and is associated with rheumatic fever. So post-rheumatic fever, especially in girls, can result in Sydenham's chorea. So here what happens, the pathology basically here, it is the antibodies which are produced by the antigens of streptococcal bacteria. They combine with the proteins of the membranes of neurons of this striatum, that is the caudate nucleus, the putamen and all, producing inflammatory changes. Okay, so the antibodies which are produced, so pathology, in rheumatic fever caused by the streptococcal bacillus, right? Streptococcal bacillus. So here what happens, the antibodies which are produced, they will combine with the proteins of the membranes of the striatum, that is basically the putamen, the globus pallidus, the caudate nucleus. So it will combine with there and it will cause inflammation of this membrane. So involuntary movements here, they are less rapid, they are slow, less rapid compared to Huntington's, less rapid and jerky. So if you do a CT scan, there is no significant finding there. Okay, and recovery here is complete. Okay, that's a good thing. There is complete recovery. As a rule, there is complete full recovery in Sydenham's. Now what about Huntington's chorea? So Huntington's chorea here, it occurs in adults. Okay, it occurs in adults between the ages of 30 to 45 years. This is a autosomal dominant, okay, dominant condition, autosomal dominant condition. So here the main pathology is, what is the pathology here? There is degeneration of GABA secreting neurons. So there is degeneration of the GABA secreting neurons of the striatum, that is in the caudate nucleus and the putamen. Okay, so because of which what happens is there is the nigrostriatal pathway, right? It cannot, because dopamine basically will be causing the through the nigrostriatal pathway, it will be causing the inhibition of the cells, right, of the corpus striatum. But there now there is no inhibition, so inhibition is not there. Okay, they are not able to inhibit the dopamine secreting neurons of the substantia nigra, because of which there will be overactivity of the nigrostriate fibers. So here because of which the movements will be more rapid and jerky. Okay, the movements will be more rapid and jerky, and in the CT scan will show some change. So you can see here the change in the, so there is enlargement of the lateral ventricle. So lateral ventricle will be enlarged. Okay, so that is mainly because of the degeneration of the caudate nucleus, because caudate nucleus is forming the boundary of the lateral ventricle almost, right? It is covering almost the entire lateral ventricle. So because of which what can happen, the caudate nucleus degenerates and the lateral ventricle will enlarge. So here sadly there is no recovery. Okay, so there is no recovery in Huntington's chorea. So this is how we see it, the enlargement. So this is the Huntington's chorea disease. Then the last condition, we have the 𝗲𝗏𝗔𝗟. So 𝗲𝗏𝗔𝗟 results due to, so 𝗲𝗏𝗔 is basically due to vascular lesion. Vascular lesion of subthalamic nucleus. Okay, so at the subthalamic nucleus, what happens is the normal, the smooth movements, the voluntary movements, they are all integrated there. Now, the different parts of the body, they are all integrated at that part, that is in the subthalamic nucleus. So, if there is some lesion on that, then that integration is affected, because of which there is violent burst of irregular movements. Okay, burst of irregular movements. So usually these movements are in the region of the pelvic girdle. Okay, girdles, that is pelvic as well as the pectoral girdle, in the trunk, okay, as well as the proximal extremities. So usually there is something what we call it as contralateral flinging, which is otherwise called as the ballistic. Okay, movements of one or both extremities. So if the disease is restricted just to one limb, we call it as monoballismus. If it is both, we call it as if it involves, okay, but involves both upper and lower limbs on the contralateral side, we call it as the hemiballismus. So why this happens is because here the subthalamic nucleus, right? So the subthalamic nucleus, if you see here, the subthalamic nucleus of one side will be projecting to the ipsilateral, to the same side cortex through globus pallidus. Globus pallidus and thalamus. Okay, so basically the 𝗲𝗏𝗔𝗟 is due to vascular lesion of the subthalamic nucleus, where the voluntary smooth movements of different parts of the body are integrated. So it is characterized by violent burst of irregular movements involving the trunk, the pelvic girdles and the pelvic girdle, pectoral girdle and the extremities. Okay, so it involves the proximal musculature of the opposite extremity and limb. Suddenly their movements are all out of control in different directions. So we call it as the contralateral flinging ballistic movements of one or both extremities. So coming to the image-based MCQs, the structure lying lateral to the posterior limb of internal capsule. Okay, so this is the anterior limb, posterior limb. So structure lying lateral, this structure is the globus pallidus. The highlighted structure together forms, okay, the highlighted structure here is the lentiform nucleus and the caudate nucleus, okay. Here we have the putamen of the lentiform nucleus and the caudate nucleus, together they form the new striatum. The most likely clinical manifestation is in this, okay, so it is the Hemiballismus here, which involves this region here. We call it as the Hemiballismus. So from the subthalamic nucleus of one side projects into the mainly to the ipsilateral cortex as well as to the globus pallidus and thalamus here. Okay, so that is why we see Hemiballismus. Section of brain showing lenticular striate arteries entering basal ganglia. These arteries most commonly arise from, they are from the branches of middle cerebral artery, lenticular striate arteries. So that's a wrap on today's session on basal ganglia or basal nuclei. So stay consistent with the series because consistency is the key to success. I will see you in the next session.